Dear audience, dear chairs, good morning, and thank you to let me introduce my PhD thesis about the novel treatment of advanced urothelial cancer. I'm Mohammed Altenni. I'm working at a Peterfield Hospital as a urologist. I'm on a mission to provide outstanding clinical treatment for patients with urothelial cancer in a strong academic environment. My vision to serve bladder cancer patients with compassion, professionalism, integrity, and excellence. To achieve these goals, I have two ongoing specific goals, both of them about the same disease, which is advanced urothelial cancer with a different kind of novel treatment. The first one about enfortumab vedotin, which is an antibody-drug conjugate binding to the Nectin-4 and then causing cells death. The second one about the immune checkpoint inhibitors. So let's start with my first project, which is identifying patients who would benefit from enfortumab vedotin in advanced urothelial cancer. Why it is important? As we know that 5-year survival for metastatic urothelial cancer is very poor, and those patients are undertreated, especially in the third-line therapy. Enfortumab vedotin is a new third-line therapy according to the EV301 randomized counter trial, which is approved the using of enfortumab vedotin in 2021 by the FDA and then by the EMA. Because of the superiority of it than chemotherapy, as we can see here, the overall survival and the objective response rate are higher in enfortumab vedotin. And we know that in real world, those patients are less selected than prospective studies. So our aim here to identify which patient with advanced urothelial cancer will benefit more from the novel treatment. Our clinical question, how do different clinical parameters impact the outcomes of EV-treated advanced urothelial cancer? We use the PICO framework and our population patient with advanced urothelial cancer treated with enfortumab vedotin, and we are comparing different patient characteristics. And our outcomes, overall survival, progression-free survival, and radiographic response by the RECIST criteria 1.1. So we hypothesize that enfortumab vedotin provides greater benefit to advanced urothelial cancer patients with these specific characteristics. We conducted our systematic search in 3 main databases by we used 2 domains, you can see below. We got more than 1,600 articles, and after the selection procedure, we got 23 articles for our analysis. So now I would like to show, interpret some of our results. Here, our first figure about the proportion of objective response rate between our prospective and retrospective studies. In the upper part of the figure, we can see that we have prospective studies, and in the lower part, we have retrospective studies, and we are measuring the objective response rate. In the upper part, the response rate is 45%, and in the lower part is 51%. And when we are comparing the 2 type of study, we got statistically significant and clinically relevant difference between the 2 studies, which is support our hypothesis that in retrospective studies, patients benefit more from the therapy. So now the second figure, we are comparing the odds ratio for objective response rate in patients previously treated with immune checkpoint inhibitors. We have 6 studies here. We are comparing responders to previous immune checkpoint inhibitors with non-responders, and the odds ratio is 1.55. That means patients who previously responded to immune checkpoint inhibitors have a higher response than patients who are not responded. Our third figure, we are comparing favorable and unfavorable ECOG status with in objective response rate, overall survival, and progression-free survival, and our outcomes is consistently suggest that the patient with the favorable ECOG status have a higher response and higher overall survival than patient with the unfavorable ECOG status. Here is one of the summary table of investigated parameters in objective response rate, and we highlighted the results which has a significant outcomes. So this is our manuscript status for the first project. We already done with the manuscript status. We would like to submit it as soon as possible, and our target journal, European Urology. Our strength for the study, that this is the first systematic review and meta-analysis, and we have a large sample size, with the limitation that we use only univariable analysis and the patient-level data unavailable for all studies. Our conclusion that clinical parameters, including ECOG status, response to prior immune checkpoint inhibitors, and platinum therapy, GFR, hemoglobin level, and tumor location are predictive for enfortumab vedotin. Our implication for practice that enfortumab vedotin is effective not only in bladder cancer, but also in upper urinary tract tumors. And enfortumab vedotin is more effective in chemo and immune checkpoint inhibitor responders, with the implication for research that mechanistic research should reveal how the identified molecular factors influence EV sensitivity, and we need further research in large real lives to assess rare molecular and histological subgroup sensitivity to EV. Now, let me show you my second project, how tumor mutation burden impact the outcomes of immune checkpoint inhibitors treated advanced urothelial cancer. Why it's important? As we know that immune checkpoint inhibitors are also novel treatment from 2016, but the problem here is that 25% of patients will benefit from this novel treatment, while 75% will not. And our aim to enhance the understanding of tumor mutation burden as a predictive biomarker and to refine personalized treatment strategy in urothelial cancer therapy. Our clinical question, how tumor mutation burden impact the outcomes of immune checkpoint inhibitors treated advanced urothelial cancer, and we use the PICO framework, our population patient with advanced urothelial cancer treated with DCIs, and we are comparing TMB positive with TMB negative patient, and we have the same outcomes as a first project. We hypothesize that immune checkpoint inhibitors provide greater benefit to TMB positive advanced urothelial cancer patient. Our clinical research implication that TMP helps select patients for effective immune checkpoint inhibitors treatment, improving care, and avoiding ineffective options. So this is our preliminary systematic search. We used the search key you can see below, and we got more than 1,500 articles. And this figure represents our outcomes or what we would like to compare. This is our second project progress. We would like to submit the Prospero soon. To sum up, we have two ongoing specific goals. We would like to submit the first project in September 2024 and the second project in 2025. I would like to thank you for your attention by my favorite quote, be brave to stand for what you believe, and even if you stand alone. Thank you.
You said that your population was the patients with the advanced urothelial cancer. How is it defined? What is the advanced urothelial cancer?
Yeah, it's that means that the cancer doesn't. It's from T3, if we are speaking of the pathological stage, from T3 stadium to the metastatic tumors also.
How feasible is that? So, is it realistic in your urology practice to analyze the patients with these methods, like to identify, yes?
Thank you for your question. Yes, we are using these parameters always when we are using such as chemotherapy or other immune therapy. So we also selected the patient for different kind of treatment. So patients who have ECOG status, favorable ECOG status will take one treatment, and with unfavorable ECOG status will get another treatment. So yeah, this is a practical things.
So it's feasible, and
It's
the
feasible.
cost-benefit
It's feasible.
ratio
Yeah,
is
yeah.
good. Do you expect measurable improvement in survival if the proper populations could be identified?
If I understand
Yes.
good your question, that you ask, we
So how
expect.
much would the survival improve in the affected?
As we can see here for the first project, in a randomized trial and also in the retrospective studies, the overall survival is much higher than the standard of care, which is a chemotherapy. The difference is here 5 months. And for the objective response rate is more higher, the response. So for sure, this novel treatment soon will be used in a daily practice. And also, enfortumab vedotin now in Western countries, they used it as a first-line therapy. So it's really very, very highly effective treatment. And during 1 year, the treatment landscape changed significantly. So now we can use it as a first-line therapy also, with a combination of immune checkpoint inhibitors.
Thank you.